We are very happy to be able to present our poster on a project on the uncertainty for proximal femur fracture classification, which was a collaboration between TUM and the Klinikum Rechts der ISA in Munich. First, we're going to talk about our motivation. Fracture diagnosis and classification can be quite challenging, especially for young, inexperienced doctors. For many fractures, right classification is essential regarding treatment and outcome. With proximal femur fractures, one of the most common fractures worldwide, even survival depends on right and fast classification and treatment. CADs have already shown to achieve state-of-the-art results in diagnosis, to reduce medical error, and to support time and cost-efficient treatment. For clinical applicability, medical experts are in need of some kind of quality control, not only for the CAD itself, but also for every single diagnosis. So the goal of our study was to provide a reliable score of uncertainty for automated fracture classification, in our case for the classification of proximal femur fractures.
Our dataset was collected from the Trauma Surgery Department of Klinikum Rechts der ISA, Munich, Germany, with a total number of patients 692 and 1,347 X-ray images. We have 3 different classification scenarios, going from the basic scenario, where the bone was annotated as fractured or not, then 2 other more fine-grade scenarios, 3 and 6 classes. In our work, we benefit from Monte Carlo dropout as an approximation of Bayesian neural network to provide a quality control measure. As for our models, we have 2 different network architectures. First, ResNet, that is adopted from our baseline, where the Monte Carlo dropout was introduced only at the last dense layer, treating the rest as a deterministic network. Whereas the second architecture, DenseNet, is a stochastic model, where the dropout layers was introduced at each convolution layer and in the transitional blocks. We divided our experiment into 2 main folds, quantitative and qualitative, starting by analyzing and comparing the performance of Monte Carlo dropout with different settings, ResNet and DenseNet models, against the individual readings of the 3 experts and also the majority consensus. In general, models introduced with Monte Carlo dropout achieved comparable F1 score performance to their old baseline models. And overall, the performance of our stochastic DenseNet models performed similarly compared to the experts' reading. Further, the coherence between the uncertainty scores and the misclassification was qualitatively measured. And results demonstrated that the misclassified mostly occur in the high uncertain region, and this is mostly apparent in the fracture detection in 3 classes. As for the 6 classes classification, shows a Gaussian distribution for the uncertainty scores with almost no coherence with misclassification. And this is in particular is the most challenging scenario out of the previous cases, and it's also aligned with the F1 score reported. Lastly, for the qualitative results, we observed the results of the uncertainty scores for each image carefully, and then picked the most interesting cases that occurred and categorized them into 3 sections. First, high uncertain and misclassified. Second, highly uncertain and correctly classified. And lastly, low uncertain and misclassified. Then we picked the top ranked from each section and referred them to an independent radiologist that is different from the 3 previous experts and the annotators. This represents approximately 30% of the test dataset. Then, the radiologist was asked to provide comments on the pictures and the fracture, specifying if the classification is an easy or challenging task, also stating if the difficulty comes from the fracture complexity or from the appearance, like contrast or brightness. We also have a reflection of the high uncertainty and the appearance of the fracture difficulty, also a reflection on the disagreement and the intra-variability between the different 3 experts.
So as a short conclusion, in our work we were able to show a coherency between misclassification and uncertainty scores, which means that a high uncertainty score means high risk for error in prediction. In our qualitative analysis, we compared the uncertainty measures with inter- and intra-observer variability. We could demonstrate that the uncertainty score is actually mimicking the radiologist's uncertainty for challenging and complex examples. Due to the extensive qualitative analysis, we could also evaluate the weakness of our model, beginning with the quality of the ground truth, for example. We believe that an uncertainty score like this can be a key element for clinical applicability of CADs. Our future work will concentrate on improving the robustness of the model, and we're planning on extending the work on different data sets like other parts of the human body, continuing with other very common fractures, for example, the distal radius fracture.